Hi, everyone. Today we're talking about pelvic health, and I have with me my dear friend, amazing pelvic floor physical therapist, Stephanie Prendergast. She's also a founder of Pelvic Health and Rehabilitation Center.
Thank you for having me. Excited to talk to you as always. As you mentioned, I'm co-founder of the Pelvic Health and Rehabilitation Center. We have multiple locations in the United States. Most recently, I'm excited to be faculty for the International Society for the Study of Women's Sexual Health, where we're helping physicians understand how to do pelvic floor exams to identify various types of pelvic floor disorders that are muscular in origin compared to the training that they have. And simultaneously working for the nonprofit called Tight Lift, where we're also trying to help bridge the gap in OBGYN training regarding pelvic pain disorders.
That's amazing, and it's all so needed. Well, when patients find the pelvic floor physical therapy and they go for the first visit, what should they expect?
That's a great question. When patients are coming to pelvic floor physical therapy, sometimes they are referring themselves. Sometimes they've been referred by a physician, and sometimes they've been sent by a friend or colleague. The term pelvic floor physical therapy, which also now includes occupational therapy, spans urinary, bowel, and sexual concerns, as well as comfort in our genital area when we're sitting, we're standing, we're exercising. The questions that a pelvic floor physical therapist will ask will cover all of those arenas, and then we'll do a physical exam based on what we've been told. So after we do a little bit of introduction time with the patients, take a history, step out of the room, patients will change from the waist down, cover themselves with a drape, and then based on what we've been told about their various areas of symptomology, we'll do a tailored physical exam. And that's going to vary from person to person depending on what their most bothersome symptoms are. Following the exam, then we step out of the room again, patients get dressed again. We then discuss what they told us, what their goals are, what the physical findings are, and devise a plan that usually happens over the course of several weeks.
When they get the exam done, what is it included? Because obviously all the patients kind of worried about internal exam being involved. Like what is done? And is there any difference for women versus men?
There's a lot of manual palpation of the pelvic girdle muscles on the pelvic floor. And a lot of the dysfunction that covers urinary, bowel, sexual concerns, and then general low back and pelvic girdle covered also involves the external muscles. If we're talking about people who are struggling with pelvic pain, it usually starts with a manual exam, and then it may or may not include a biomechanical examination of how the lumbopelvic hip mechanics are working. So to give a simple example, if somebody has vestibulodynia because of oral birth control pills, their physical exam is going to look different than somebody who has pudendal neuralgia, which is more mechanically induced compared to something that's more pharmacologically induced. So based on the information that we get, we will pick and choose how to handle the initial evaluation.
And so you mentioned a few conditions that both you and I are treating, but I think majority of people, they know about pelvic floor physical therapy in the context of doing Kegels because you have a urinary incontinence, a pelvic organ prolapse, but there are a lot of conditions that require pelvic floor physical therapy, but not as known. Can you just describe some of them, like the most common one that you deal with that's not actually that known?
So pelvic floor physical therapy spans an umbrella of what we used to call low tone to high tone disorders. We know now it's more nuanced than that, and a lot of it is a hybrid. Lower tone disorders include things that happen as we age and around peripartum care, stress urinary incontinence, pelvic floor dysfunction as urogynecologists see it. The pelvic pain conditions that pelvic floor physical therapists are involved, it's really only been in the last 20 years since I've been practicing where physical therapists are dealing with the pelvic pain scenarios. This includes the vulvodynia umbrella, and that also includes symptoms such as irritated bladder symptoms, which can or may not be classified as interstitial cystitis, painful bladder syndrome. Pudendal neuralgia, but a lot of the symptoms of pudendal neuralgia also span the other diagnoses that I'm talking about.
You mentioned pudendal neuralgia, and I guess we do see those patients commonly, but what's the most common symptoms that patient experience who has a pudendal neuralgia?
So pudendal neuralgia just means pain that is neuropathic in the territory of the nerve, but that nerve goes to a lot of places. This is a mechanical condition that in cases of neuralgia without entrapment, and we're going to have to separate out the two, commonly people have pain with sitting, and it's going to be in the perineum in both genders. The other branches that go to the clitoris and the anus are more likely to be affected by obstetric injuries, hemorrhoid surgeries that have gone wrong. And the reason I noted neuralgia versus entrapment is because the neuralgia crowd can have an insidious development of symptoms that start to accumulate into unprovoked, persistent neuropathic pain. Whereas some of the entrapment people, there's usually a more obvious situation in their history, as I mentioned, like a hematoma on the pudendal nerve, having some of the mesh complications that patients have had, or some of the other surgeries that involve the anal sphincter area. And so it's a problem because we don't have diagnostic tests to separate the two crowds of entrapment versus neuralgias. So we have to really keep in mind what the patients are telling us with their stories to figure out if something more medically needs to be involved or some combination of both.
So, and you as the specialist in pudendal neuralgia, what are some things you wish people knew, and what are the other diagnoses that's very similar to pudendal neuralgia?
A lot of the diagnoses that we have talked about are clinical diagnoses of exclusion. I think lately there's been a lot of focus, like I think as our vulvar dermatology knowledge has increased, we're realizing how many people have clitoral adhesions and things like that. And I feel like it's being overdiagnosed as clitoral dynia by pudendal neuralgia origin. And I just want to encourage people to think back to the history. How would that even happen versus looking under the clitoral hood? And I had multiple experiences over the last 2 years where people came to me because my interest is in pudendal neuralgia, when in fact there were adhesions or clitoral phimosis or keratin pearls or things that made more sense with their history than a mechanical entrapment or neuralgia. So I really think with interstitial cystitis, with clitoral pain, vestibulodynia, things can burn, and we need to figure out if it is a vulvar issue, a muscle issue, neuropathic pain. And I think most of the time it's not a pudendal neuralgia, but it mirrors the symptoms of it. And so people understandably think that. But if there's a keratin pearl and I put somebody on Lyrica, that's not going to work.
So what's the role of pelvic floor physical therapist in a treatment of pudendal neuralgia?
Our role is very important in the treatment of pudendal neuralgia, especially if there's been an insidious onset. Because of the course of the nerve through all the pelvic floor muscles, the obturator, internus, there's a lot of mechanical changes that go on. A lot of patients can't sit comfortably. They can't exercise the way they want to. They notice if they go walking up a hill, which is hip flexion, very difficult for them. If they were to walk backwards up the hill, they absolutely could do it. So that is more of the mechanical intersection between the pelvic floor and the pelvic girdle, and helping people reorganize basically how their body's moving. Again, hip flexion, piriformis stretches, hamstring stretches, things that you would think are normal and healthy can actually be tremendously challenging for people with these mechanical issues. And it's because the nerve can't slide, glide, and move in one of those places. So our job is to figure out where and then help restore those normal mechanics. And that can involve anything from manual therapy to neuromuscular reeducation to pelvic floor or obturator internus Botox, pharmacologic medication. All of these things can come together to get people comfortable again.
Well, how about another condition that you mentioned, the interstitial cystitis? What is the role of pelvic floor physical therapy in treatment and management of the interstitial cystitis?
It's a very sensitive thing because nobody thinks when they have these severe bladder symptoms that they need a physical therapist. And so, of course, people don't think that. And between the medical side with what you do and the physical therapy side, we have to figure out what's muscle, nerve, and bladder and try to help our patients figure out what are the therapeutic targets for them. Because as we know with this disorder, there's a lot of different reasons people may have these symptoms. And that's been very helpful because so many people with IC feel like they have burning. They think they might have pudendal neuralgia. And so one of the roles we play is helping to discern what's the nerve, working with you what's maybe bladder, and then what's the pelvic floor component, which mirrors all the other things.
Yeah, that's so true. And actually, that also brings us to my next question. I have been seeing so many patients who has a hypertonic pelvic floor, and they all have like urinary issues like frequency, urgency. I think there is a significant increase in this patient population after pandemic. Can you talk a little bit about what you do for patients with hypertonic pelvic floor?
The words we used to say were hypertonic pelvic floor. In a clinical setting, if I don't have EMG and I'm using my finger, we're trying to associate hypertonic with myalgia, which means muscle pain, because a lot of the studies have correlated if the muscles hurt on palpation, they're associated with that higher EMG and a hypertonic pelvic floor. And so it involves down training the muscles. We are doing manual therapy and literal biofeedback with our fingers to help our patients learn how to control their pelvic floor, because most people who have hypertonicity, they can't move the muscles the way the rest of us do involuntarily and voluntarily. That's the other thing with the pelvic floor is some of the reflexes that come from the bladder, we don't control. The more the bladder fills, the tighter the pelvic floor gets. That's normal function until we go to release. Some patients can't do that. They try to start their urinary stream and they feel like they're sitting there for 5 to 10 minutes. They hear people in the stalls and they know that they're not doing what they're hearing. And so our job is to help them understand why and then retrain so they can sound like that person in the stall next to them who starts their stream right away and is out of there and washing their hands in 30 seconds.
Yeah. So I know we've been talking about like a hypertonic pelvic floor and some like weak pelvic floor. What's the difference and how you can distinguish one from another?
So a good differential, hypertonic versus weak pelvic floor. In general, when muscles are hypertonic, they tend to hurt, which is what we call myalgia upon palpation. We always talk about the pelvic floor, but we cannot exclude the obturator internus because that's an important muscle that we can palpate transvaginally, makes a 90-degree angle around the sit bone. You can feel it both in the pelvic girdle and in the pelvic floor muscles. Weak muscles truly mean we can't have somebody squeeze either on command, push on command, and their muscles may not even move when they inhale and exhale. That can happen in both groups, but in general, the people who have weakness do not have pain upon palpation. With the high tone disorders, there is more hesitancy, constipation, pelvic pain, inability to orgasm on the subjective side. It just doesn't feel normal. And the low tone may lose their ability to feel their orgasm as strongly as they did. That can come back when their muscles can contract again.
Let me ask you about very controversial topic, Kegels. When is it good? When it's not that good to do them?
Kegels are a controversial topic, and why? I think I have some insight to why. And it goes back to the pelvic pain, hypertonicity versus low tone pelvic floor disorders. Initially, when I first started 25 years ago, everything was about Kegels and strengthening, but things have evolved since then. And we now know that some people who have the same symptoms as somebody who's weak may actually be tight, and they should be doing reversed Kegels. They may be tight in certain areas, weak in others, and it's not as straightforward as everybody who's leaking should be doing Kegels. Everybody who has pain should be doing foam rolling and pelvic floor drops. It's really about making sure that the involuntary function of the pelvic floor is working. Does it lengthen when they inhale? Does it shorten when they exhale? Some people, they really don't do that. And again, just doing Kegels alone aren't going to matter if every time you take a breath, your pelvic floor isn't doing what it's supposed to be.
You mentioned reversed Kegels. What is that?
It's a big question and questionable terminology. So a reverse Kegel to me can mean a few different things. I'm looking for normal function when they breathe, cough, sneeze, laugh. But also, can they push my finger out of the vagina if my finger's in the vagina? That to me is what I would call a reverse Kegel, because it's an active muscle contraction, but it's eccentric. So the muscle's lengthening versus shortening. And so that's why we say reverse Kegel, because Kegel means contraction. And when people evacuate stool and urine, it's really an inactive let go. But for the people who can't do that, then they're pushing.
And how long does it usually take? Like, is it like, are they need to go in a pelvic floor PT forever? Like, I understand everyone is different, but average time.
Average time, usually, especially if we're talking about the pain conditions and the hypertonus issues, they're probably going to have at least 12 visits, and that may be spread out. Typically, we do once a week, and that may be spread out over time if they don't need as much as the hands on. We give our patients the hands on things in the clinic that they can't do for themselves at home. And then at home, they can do things like the foam roller and diaphragmatic breathing and trying to retrain their pelvic floor. And then we discuss it again in the visit. Now, some of the more complicated cases, if people have had pain for 5 to 10 years, they may be with us a year or longer. And again, it takes time, just like with hormone therapy or whatnot, or if we're doing a new gym routine, it probably takes about 3 months to make a change. And so we'll adjust the treatment plan as their impairments lessen and their function improves. So we start with a basic program that almost everybody has with pain, and that involves the foam rolling and the Theragun because the somatic pelvic girdle muscles also are involved. And patients can easily work on that themselves while we're helping them get the pelvic floor situation back under control.
People go to pelvic floor physical therapy when they have urinary incontinence, like stress urinary incontinence or prolapse. But do they need to continue going to pelvic PT even if they had a surgery like a sling or had a surgery for the pelvic organ prolapse?
I would recommend if they had to have surgery for any of the conditions that we just said, they should also have an evaluation afterwards, just to make sure again that the neuromuscular system is working properly. And it doesn't have to be forever if we get them functioning normally again. But if they're not functioning normally, then other symptoms are going to start to show up: low back pain, hip pain, failed surgery. As we know, there could be a shelf life if they're coughing and they're constipated, and the surgery may not hold as long as we want it to. So trying to make sure those functional things that could negatively affect their prognosis are addressed is one of the reasons I think we should be involved.
Okay. And let me switch the gears and let me ask you, because you helped me a lot when I was recovering after my C-section. So can you talk a little bit what happens to pelvic floor when we have a C-section and why it's so important to go and see pelvic floor physical therapist?
Oh my gosh, and thank you. I know for all the pregnant persons and the new moms, I mean, think about if you've ever had an ankle sprain, you go to physical therapy. Why are we not after this physiologic miracle of pregnancy, delivery, and birth? And I really think everybody should have a physical therapy evaluation after they deliver, even if it was the most perfect delivery. And C-sections, it's a major abdominal surgery. And our pelvic girdle changes and our ways that we interact with our pelvic floor, those reflexes I mentioned, may not be intact, and people don't know it. Simple signs like a little bit of stress incontinence, inability to orgasm, painful sex, while it's not ruining somebody's day because they may be situational as they're caring for their new family, those are symptoms that something isn't right. And there's a high rate of pubic symphysis separation, diastasis, levator ani avulsion that may or may not manifest in a way that's bothering people enough. And because we're a reactive society instead of proactive, I think that it's not standard of care, and it needs to be. But you know what? This generation's figuring it out. People know, even if their OB isn't referring because insurance companies don't want to pay for it, that they went through a major physiologic change and they should get evaluated.
And in terms of like pregnancy and delivery, do they women need to see the pelvic floor physical therapy after the delivery, or there is something else that can be done while they're pregnant?
So I would say both. It depends. And again, I think the person who is pregnant may not be aware of what their body's doing. And that's why I say there's a reason to get at least an evaluation. And then the evaluation can decide, do you need physical therapy now, or should you have it after? Everyone should have it after. And the new phrase is postpartum is forever. Bodies change with this. And at first, especially between baby 1 and 2, for a lot of mothers, they're overwhelmed. They're taking care of the baby. There's not time to take care of themselves. But then we see more complications with pregnancy number two, and then more problems postpartum after delivery number two because these things weren't rehabbed to begin with. And then I do think everyone postpartum has to have it, regardless of what time frame that will work for the mother, but definitely before a second pregnancy happens.
Are there any exercises, stretches that pregnant women can do in order to minimize the injury to the pelvic floor to help prepare them for labor?
Yes, it's important not to start to do a tremendous amount of things that are different than the normal routine. So I know some people sometimes are thinking, okay, I'm pregnant. They get targeted on social media by all the things you should and shouldn't be doing. But if you weren't doing CrossFit to begin with, maybe it's not the time to start with that now. There are some physiologic things that we know happen during pregnancy, such as the hip flexors getting tight, the external rotators and adductors of these muscles. So there's generalized things that most pregnant women can benefit from. If there is other additional concerns, sciatica, pubic symphysis issues, urinary symptoms, not outside of like the normal pregnancy feeling, then the care will be more individualized instead of generalized.
I just actually, when you were talking about starting CrossFit, I remember how when I asked you after I delivered, like 1 week after, I'm like, Stephanie, I tried to run and it didn't work.
I
And you
was so mad at you.
and you were like, wait, you will be able to like run in like 8 weeks. I'm like, yeah, but I never ran before. And you were like laughing.
I know. I'm like, well, then don't start now. But I do think people get targeted with like as soon as you're pregnant, just like people are in menopause right now and peri. And it's just like they're being told to do all these crazy things and it's like not necessary.
Yeah, totally. There are a lot of women who I see who had the babies and I do exam. They look like has some laxity, but it's not real prolapse. But they feel like sex feels different. They feel what they call loose. Is there is any role for pelvic PT to help women with that issue?
And I feel like this is a good discussion for both of us because, yes, how long do we feel like it takes women to feel less uncomfortable like that? And again, there's varying degrees between vaginal deliveries, C-sections, their genetics, what they went into their pregnancy with. I think it's inappropriate that people aren't being warned if they're already either Danlos or hypermobile, that they may have some different challenges than people who are not. And how long does it take? I mean, of course things feel different. I mean, but telling people that it should, I think is helpful as we try to rehab them after, because of course it's not going to feel the same if you just had a vaginal delivery and then it isn't going to feel right for sometimes at least a year.
How about women who, let's say, had the babies like 10, 15 years ago, and now they feel like loose, kind of passing air through the vagina? And do you think
Yeah.
it's mostly like a muscular, or is it more like a nerve involvement? What would you do with those patients?
And so the nerve involvement, we don't know unless there's pain, right? Because they're not doing PNLTs on everybody, which they shouldn't be. But I think it's perimenopause and unrehabbed postpartum issues.
Some people have the stress urinary incontinence after delivering babies, and some have it without delivering babies, right? So we do know that there is two different reasons why they might have it. Have you noticed that one group actually has a better outcome after pelvic PT versus another, or is it work equally well for both groups?
It is a good question. I think of my teenage athletes who had stress incontinence and they're 17 and clearly have not been pregnant, but they're gymnasts and ice skaters. And, I think the higher tone stress incontinence crowd is more difficult than some of the more standard age related or physiologic related perimenopause and postpartum changes. I feel like when people are high tone, again, there's so much neuromuscular imbalance that their bodies just don't respond as quickly as somebody who maybe just actually is weak. And it's fascinating, really, to see the difference.
Okay.
Good question. And I don't think that's been studied, but I definitely have observed that over the past 25 years.
Okay. So if there is any interventions that people can do or like life adjustments to improve their pelvic health, what would those interventions be? Like a squatty potty or like having regular bowel movement? Is anything that you would recommend?
It's hard because I sound so self-serving. I'm like, let me do an evaluation so I can make recommendations based on whatever may or may not be going on. And again, sometimes it's nothing. I feel like people are fine. And then other times we need to add in a few things. You mentioned the squatty potty. I feel like most people should have a squatty potty because bowel and constipation is one of the leading things that can create more pelvic floor dysfunction that affects urinary and sexual function too. We love the foam roller and the Theragun. Sometimes stretching may actually be the wrong thing for somebody, depending on if they have some sort of pudendal or sciatic nerve issue going on. Whereas the foam roller and the Theragun is almost always tolerated because it's not putting people to end range. So they can actually reduce the muscle tone without having to lengthen something around a joint that could provoke a nerve. The other thing that actually really matters for pelvic health is meditation and breathing. Now, I'm a horrible, I don't follow my own advice person. But when we inhale, the pelvic floor lengthens. When we exhale, the pelvic floor shortens under normal circumstances. It's also very tied to the central nervous system, which more so than other types of pain issues in the back and whatnot, the breathing and the connection to the nervous system, because of that involuntary movement, can actually do more than people think. So while they are suffering with severe symptoms, I'm not telling them they can breathe their way out of it, but I am saying that the breathing may actually do more for their pelvic floor than trying to use a dilator when maybe they shouldn't be because there's other issues going on like vestibulodynia.
What are some obstacles that you see patient facing in getting a proper physical therapy evaluation and treatment?
The obstacles that patients are facing with getting appropriate physical therapy treatment are multifactorial. Number one, we have an education problem. Insurance companies do not recognize physical therapy or occupational therapy as a specialty. On the medical side, people trust their physicians. And until something like this happens, they don't realize that their OB may not really understand the scope of what their pelvic pain syndrome is because they didn't have training. And then there can be some communication challenges because they don't even know that physical therapy is something that can help the patient. And therefore, if it wasn't told by their trusted doctor, I think the patients are nervous. Why didn't my doctor tell me? There's training, political, all kinds of problems. And some people still don't feel comfortable talking about it. But I'm really glad to see now versus when I started that so many more people are. And we're recognizing the gap so we can make it better.
And you mentioned in the beginning that some patients can be self-referred and some patients referred by the physician. In general, do they need to have a referral? Do you need to for them to have a doctor who would send them to you?
So most states in the United States have what's called direct access, which means that people can just go to physical therapy without a referral from a physician. I mean, we prefer to work with our medical community because many of the issues that our patients are coming to us for are not just physical therapy. That's why you and I have formed such a special relationship. It's really both, but we tend to have, for insurance purposes for our patients, a physician needs to sign off on the evaluation within 45 days for most patients to get reimbursed by their insurance company. But again, sometimes physicians have told our patients, well, you've got an incurable, intractable bladder disease, and you're just going to need to know where the bathrooms are the rest of your life, versus being referred by somebody like you who says, I know what's wrong. This is part of your problem. Physical therapy and my treatment is going to help you. And so we just have to really see what the patient is coming in with because depending on the different scenarios, they've been told many things.
Are there any advice that you can give women how they can advocate for themselves?
Yes, I think listening to their bodies, talking to their friends, talking to their medical providers. Women can have the conversation and not have to make a decision based on the feedback they're getting from any of the people that I just mentioned. Just take in the information and see what feels right and makes sense. And just know that it's not easy. I wish everybody could have access to everything that we're talking about. And we know that that's not possible, but it isn't impossible either. Sometimes it just takes a little more work than you'd expect to get to the end of this.
And how people can find you?
I'm very findable. Our website is pelvicpainrehab.com. I currently see patients in our Pasadena and intermittently our West LA location, and we are in the Bay Area, Southern California, and New England.
Thank you. Thank you so much, Stephanie, for joining me and talking about pelvic floor physical therapy. I think I learned a lot, and I'm sure people who listen to us also learned a lot. Thank you. Thank you so much for everything you do.
Thank you for having me, and thank you for all you do too.